My name is Mary Koshi. I'm an Associate Director in the Office for Diversity and Inclusion, and welcome to our virtual educational talks for Disability Awareness Month. We've had a few last week, and this is our second week hosting these virtual talks with our partners throughout the health system and our community. So today I am really honored to welcome our friends and partners with the National Multiple Sclerosis Society. I have Andrea Arzt, who is the Director of Healthcare Engagement, as well as Debby Bennett, who's the Program Implementation Manager, who will be joining us today. Just some housekeeping rules. I am taking attendance for those social workers who do need CEs for this talk. And if you are logged on without your name showing, please, if you can change your name so that I know who you are, so I could, instead of the phone number, so that I can check you off as being present. And please mute yourself as well. And I believe Debbie and Andrea would like to save the questions till the end, but if there is something that you do want to ask and not wait till the end, please put it in the chat. And, I'll monitor that for you. But otherwise, I will pass it off to Debbie and Andrea to take us forward with today's talk.
Thank you, Mary. Thank you so much for having us. So we have a similar slide. This is just to make sure that you know I'm Debbie. She's Andrea. There'll be a test later. You can move past this slide because I guess you get who we are. It's always a fabulous opportunity for us when we get to talk to people about multiple sclerosis, especially clinicians, because they're our focus. So as you see on the screen, this is what our agenda is, a brief overview. Well, I shouldn't say brief, I have a lot of material to cover. I'm gonna try and talk really fast so I can get through it all. So an overview of multiple sclerosis, some of this might not be new to some of you, and some of it might. Andrea will then cover the impact of COVID-19 on people with MS, and as well as the psychosocial aspects. And then she'll kick it back to me for a little brief review of what the National MS Society can provide. So next slide, please. Okay, here we are. MS is an unpredictable disease of the central nervous system, which includes the brain, the spinal cord, and the optic nerves. So we consider MS to be an immune-mediated disease, not autoimmune, because we don't specifically know the antigen that causes it, but MS does attack myelin, which is like a fatty substance surrounding the nerves in the spinal column. It attacks oligodendrocytes and nerve fibers. What MS is not is contagious. It's not directly inherited. It's not always severely disabling, and it's not fatal except in fairly rare instances. Next slide, please. So we don't really know what causes MS, but there is a genetic predisposition. So having a close family member definitely increases the risk. There is some type of environmental trigger, whether this is a virus or bacterial in nature, also not quite sure. The immune-mediated aspect, and this causes the loss of environment, loss of myelin, sorry. Next slide. So this is a great cartoon which shows exactly what's going on. So misguided immune cells, or the T cells, are crossing the blood-brain barrier. Never a good thing. This attack causes inflammation and then destruction. So the nerve fibers themselves become under attack. Once the nerve fibers and the myelin have been damaged, so then the signal that's going from the brain down to the rest of the body gets disrupted. If you picture those orange electrical outlet cords that get plugged in, and you picture the orange coating as the myelin, and it gets scraped away, and scars get left in its place. So these are like MS lesions along the path get left in its place. That's actually how MS gets its name many scars, MS. And so now if the myelin is ripped away, and you see on the bottom, the signals now are, interrupted. So that's what often causes the symptoms of MS. Next slide, please. This is a litany of symptoms of MS. I'm not going to go through them all, don't get nervous. The one takeaway that you will have from today is that MS is a disease that is unpredictable. It is different from person to person. It is even different within an individual. And by that, I mean somebody could have optic neuritis as their initial symptom and then never have that again and have something else. And then the person next to them might never have a visual problem and their symptoms are somewhere else. So you really never know from day to day what the symptoms are going to bring. I'm just going to mention some of the most common ones, like fatigue. There are about 80% of people living with MS who say that their fatigue significantly interferes with their activities or daily activities. And it's not the same kind of fatigue that you or I might experience if perhaps you didn't have a good night's sleep. This seems to be an overwhelming, exhausting fatigue, often causing people to have to take a rest period sometime during the day. Depression is more common than the general population in people living with MS. And cognitive changes, there are at least 50 to 65% of people who experience things like difficulty processing information or memory loss or problem solving. But I'm going to stop there because Andrea is going to address those a little bit later. Next slide, please, Andrea. So who gets MS? So generally, people between the ages of 20 and 50, I mean, that does not preclude being diagnosed prior or after those ages. In fact, there are about 10,000 children who have multiple sclerosis, and I know a lot of people who've been diagnosed after the age of 50. But gender tends to have something to do with MS. That suggests that hormones might be involved. They play some kind of a significant role. Ethnic background, for sure. Susceptibility rates definitely vary amongst these populations. But actually, recent findings have shown that Black women have a higher than previously reported risk of being diagnosed with MS. Living in a cold, temperate climate like ours tends to see higher risk. And again, the risk in family, the predisposition is definitely significant. And about a year or so ago, a new study was done that showed the prevalence in MS. Prior to that, we were using very old data and thought that about 400,000 people were living in the United States with MS. And we know now that that's not true, that it's closer to 1 million people. Next slide, please. So diagnosis. So a neurologist will do take a medical history, will do a neurological exam, and a couple of laboratory tests like MRI is generally the gold standard. Makes it possible to see lesions in the white matter and evoked potentials, which they track the electrical responses to stimulation along the sensory pathways. And sometimes the evoked potential can identify the damage along these pathways if a person is or is not experiencing some type of symptoms. A lumbar puncture, I think not used as often as it once was, but that is also used to examine cerebrospinal fluid, looking for characteristics of MS. And so basically what a physician will look for is evidence of dissemination in time and space. So, the evidence is the scarring in at least 2 different areas of the central nervous system occurring at different points in time. Next slide, please. So these are 4 different types of multiple sclerosis. The first one, clinically isolated syndrome. This is like an episode of like initial neurological symptoms that that could be caused by inflammation and demyelination, lasting about 24 hours. But it doesn't quite yet meet the criteria of multiple sclerosis. So people experiencing CIS may go on to develop MS, they may not. Relapsing remitting is the most common form of MS. It affects about 85% of people, and it's characterized by clear attacks, usually followed by like a full or partial recovery, and no or limited disability that happens in between attacks. Secondary progressive MS, a large majority of people diagnosed with relapsing remitting will move into the secondary phase within 10 years. And this means that we see more progression of disability in between attacks. And primary progressive MS only affects about 15% of people, but these people experience a worsening neurologic function from the onset of diagnosis, with no attacks or remissions that go along the way. Next slide, please. And so treating MS. So we use steroids for acute.
Like sliced provolone. Why? What do you want to use for?
Somebody have their
Yeah.
not have their mute button on. Thanks. So steroids are often used for acute attacks. They don't have to be. Often relapses will fade away on their own, but a lot of physicians use corticosteroids to speed that up. The disease-modifying therapies, of which there are 22 that have been FDA approved, which is like super amazing.
Usually the sore throat is the first sign of a cold, so you have it for like a day or 2 or 3 maybe, and then it moves up to like congestion.
I'm sorry, can you please,
you know, usually the first early time you have it, it's like the most uncomfortable, and then.
Debbie, can you unmute yourself and you may continue?
Sure. Well, it sounded like we were competing with somebody else who had a little more knowledge than me. So I don't want to listen in on someone else's, experience. Disease-modifying treatments have actually shown to slow disease progression and reduce relapse rates. So the Society's Medical Advisory Committee has recommended that treatment with a disease-modifying therapy be considered as early as possible, and stay on for as long as a person generally is living it. Although I've heard recently that once you reach a certain age, like, I don't know, 60 or something, they're now starting to look at whether treatment should continue, but that's for another day. Symptomatic treatments, they don't treat the underlying disease. They don't have impact on the underlying disease, but they will help, fatigue, spasticity, depression. There are all sorts of treatments. Rehab. Very important to restore and maintain function, and improving or enhancing quality of life with things like complementary and alternative medicines, cooling devices, yoga, exercise, any kind of stress reduction that improves quality of life. All good stuff. Thanks. And of course, because MS is such a complicated illness, and it impacts many functions, we like to recommend a comprehensive care team. This is an approach with a multidisciplinary approach that includes a neurologist, sometimes a PA, a nurse or nurse practitioner who coordinates care. Many symptoms need to be managed by specialists, like voc rehab counselors, physical therapists, occupational therapists, psychologists, neuropsychologists, is a whole team. And what I hope many of you know is that there is a comprehensive care team right here at Mount Sinai. It's called the Corinne Goldsmith Dickinson Center for MS, and it happens to be one of the most renowned MS care centers around. So we're happy to have that relationship with you. I'm now going to kick this over to Andrea because she'll talk a little bit about the impact of COVID. And then if you have a couple of questions that you want to sneak in before we move on, we can do that too.
Sure. Thank you, Debbie. And thank you all for joining us today. So of course, with this time of COVID-19, how that interacts with people who are living with MS is a question that we at the MS Society have been very involved in trying to figure out. Just like all of us, as we are learning about COVID and our information about COVID, it is changing and growing, it feels like day by day. So is what we're learning about the interaction between COVID and MS. But what you should know is that right now, the representatives of the National Multiple Sclerosis Society, our National Medical Advisory Committee are working constantly with the Multiple Sclerosis International Federation to try to develop COVID-19 advice for people living with MS based, again, on what we know. And a lot of what we know are both from studies that are occurring. There are several registries that are being put together as people living with MS are hospitalized or that we know are diagnosed as positive with COVID, that the information is being put into database and registries so we can try to see what this means for people living with MS. So far, though, the two key findings are that one, simply having MS does not seem to increase the risk of contracting COVID-19. So although we're aware that MS itself is mediating the immune system in some ways, and that is how many of the MS medications work, it does seem when we look at who's hospitalized and who is becoming positive of COVID-19, that there really are there are fewer people with MS than we had actually initially expected. We had actually thought that this was going to be hitting the MS population incredibly hard. And it actually is not in any different a way than it is for general populations. Of the 22, you just heard medications, what we seem to think right now is that with our limited evidence, it seems unlikely impact from most of the MS medications. There are one or two medications that because each of the medications interacts and works to mediate the MS in a different way, that might have an effect because of what they target in MS that might interfere with the COVID-19, but even that is not really shown to be clear yet. But if you have patients that are taking ocrelizumab, also known as Ocrevus, or rituximab, which are also known as Rituxan, that those people might want to consider self-isolation or a little being more careful to reduce their risk of infection. But what we are saying always is that each person who has MS and is taking some medication really needs to talk with their neurologist and their doctor, because you always want to balance the risks of stopping or delaying treatment and balance that with what seems to be a not really clear increase in risk of contracting COVID. What we've also found is that, again, simply having MS does not increase the risk of dying from COVID-19 or even having a more complicated course. What we've actually found for people living with MS is that it's actually some of the same factors that we found for people in general that are creating a higher risk. So for those people who have MS and have underlying lung and heart conditions, people with MS who are older, say older than 60, people with more progressive MS, which often really includes higher levels of disability, which also may be decreasing their functioning in other ways, also may have a more complicated course. And people with obesity, body mass of 30 or higher might be at a greater risk. But that, again, if you'll notice, these are some of the same things that we're saying for people in general. What we are also seeing is that there does seem to be a relationship for those people who are Black or other minorities, again, in the same way that in the general population. So what we are generally saying about risk for COVID-19 and MS is, again, that people with MS should really be doing the same safety and keeping themselves safe as those in the general population, and really be in close talk with their practitioners about the medications that they are on. Before we move forward, as Debbie said, are there any specific questions about this or about any of the information about MS in general? And if no?
There are two something in the chat box, which I didn't open. I didn't open it yet, but I noticed that there's a.
That was just me, ladies.
Oh.
Okay.
Great.
All
You
right.
have lots of questions, Mary, or just putting notes in there? Okay.
If,
All right.
there are no more, if there aren't any
If
questions,
there are questions, we'll keep on going.
Yeah, great.
So that's great. All right. So with all of what we've told you and about MS and about COVID-19, what we really wanted to talk about now for this second sort of portion of our presentation is really talk about the psychosocial aspects of multiple sclerosis and why MS is such a challenging disease beyond medically, but psychosocially and emotionally for people living with MS. So one of the most important things, and some of these things may be very clear, is one thing is that it's a chronic disease with no known cure, or at this point, no completely effective treatments. So the good news is it is not quickly fatal, but of course, the bad news is that if people are being diagnosed when they're 20 or 30 or 40, they're going to be living with this disease for a very long time. And that has its own anxieties and difficulties that go along with it. It's variable, and as Debbie was talking about, variable and unpredictable with no clear roadmap. So that is one of the hallmarks of MS, and it is actually this sort of variable and unpredictable nature of the disease that's really the majority of people with MS and their family members often find most difficult to handle, that they don't really know quite how to plan, they don't really quite know what's going to happen to them, and there's no one can just tell them this is what you should do and this is where it will all end up. That creates a lot of anxiety. It involves ongoing change and loss, and because it is not only a chronic disease, it is a progressive degree disease for most people. So that once you get used to something, there's going to be a change, and it may be changing all for the many years that you have the disease. And the change and the loss can be of function, of your abilities, perhaps of valued activities that you were wanted and loved doing and can't do anymore, or just simply a sense of control over your body and your life. And although we all know that probably we have less control of our body and our life than we all like to think, There's nothing like getting diagnosed with a chronic and progressive disease to put that point home to you. It's very expensive. And I think that's a piece that we need to think about in all kinds of ways. It is certainly an expensive disease as it relates to money, depending on your insurance. The MS medications are incredibly expensive. It could be anywhere from $15,000 to more a month to be on many of these medications. And again, depending on insurance and what it covers and what it doesn't cover. But we're also talking about time, emotional energy, and those less tangible resources as well. You know, when too many of important resources are drained by MS, the needs of not only of the person with MS, but of other family members also can go unmet. And then you kind of result in a disabled family, then with a family with a disabled person in it. And I think that's an important concept to keep in mind in terms of working with the entire family when someone is diagnosed with MS. It also confronts people with complex choices for which there are no right and wrong options. And there are now a variety of life choices available to people, including 22 different medications, some of which are more effective than others, but many of the more effective ones also have higher risks, more side effects, and really lots of decisions related to that. So there's treatment options, there are employment options. Should you stay in this job? Will it not be able to, or school, will it be a career that you're not going to be able to keep down the road if things change for you, or even childbearing options. So there's lots of decisions to be made all along the way. And a lot of distress now focuses around fear of making wrong choices.
Andrea, we have a question in the chat, if I may.
Sure, of course.
Yeah, I think Debby just answered. Somebody wanted to know if it can be passed on to your children.
Right. So I think Debby probably answered. And what we do know is that there is a genetic component to the disease, but it is not directly inheritable because it's not one gene, it is multiple genes. So I don't have the statistics in front of me, but I think we know that there are multiple genes involved. And the more family members, close family members in your family that have MS, then the higher the percentage chance of someone else in the family getting MS. However, it is not directly inheritable. Hope that answers. But it becomes one of the choices and questions that people have. So when we talk about common feelings among people living with MS, I mean, I think for most of you, particularly if you're social workers, you know a lot of these feelings and issues, and they're not uncommon with almost any loss or any disease. You'll have grief, which is a normal reaction to any loss, again, of self, personal identity, feelings of autonomy. Particularly, I think, because people are often diagnosed in young adulthood when your whole life is ahead of you and when you're just starting, whether it's college, your career, your family. It can be a very large blow and sort of and really change someone's sense of just control over themselves and their future. Anxiety, again, because of the unpredictability, anger, to the unpredictability, loss of control, and a lot of guilt that often goes along in letting other people down. And what's also important to also know is that these reactions ebb and flow with the ups and downs of the disease course. So it's not just necessarily after the diagnosis that someone may feel these things. Each time there might be a change in the course of the disease for someone, or a change in their functioning level, they may have to deal with this again and again. One of the ways that we kind of look at, like to look at this about grief and sort of reorganizing our self-image is if we kind of look at ourself and our views of ourself kind of as a puzzle. And so we've sort of through the years put together all these characteristics of ourselves, you know, whether we're creative, disorganized, we're warm, we're single, we're married, we're rich, we're poor, or somewhere in between for many of us, you know, whatever our age is, our sex is, all of these characteristics, our career, our other roles. And then somehow this piece of MS that we hadn't expected, this diagnosis is somehow put upon us. We need to figure out where it fits in. Now, sometimes in the beginning, if you've ever done a puzzle, you try to shove a puzzle piece in, and what do you find? The entire puzzle falls apart because it doesn't fit. And sometimes for some people, that really things fall apart, and then they have to put the puzzle back together again and figuring out where the MS fits in. And for some people, this is an easier process. But I think it's a good way to think about ourselves as many parts, with always new pieces coming in, but MS is a big puzzle piece. And again, when you think about the grief, every time that MS changes, then changes things for a person, then they have to sort of go through the whole response. Some people call it like finding a new normal. And many people with MS will often talk about how they say to themselves, well, I'll be okay as long as I can keep my job, as long as I can walk, as long as I'm still able to do X, Y, or Z thing that feels really important to me. And sometimes as things change with MS, they reach that point that they thought they weren't going to be able to deal with, and then they deal with it. And that sort of becomes their new normal. But first, again, sometimes they have to let go with that image of themselves that they thought they couldn't go on without, and kind of reshuffle the puzzle pieces. So for someone who's newly diagnosed with MS, these are some of the things that they may have to deal with from the very beginning. One of the big things is dealing with invisible symptoms. If you saw quickly that list of symptoms that Debbie showed us in the little blocks earlier, there were a lot of symptoms there, but many of them were not things that you could observe. Sexual symptoms, bowel and bladder issues, visual and vision, fatigue, in particular, depression, cognitive issues. None of these things are anything that people can see from the outside. So it's what some people call the "but you look so good," trying to understand that someone can still be feeling badly and not feel good and be dealing with issues when other people can't see it. And particularly, this is an issue in the beginning. Finding the right doctor, locating an MS specialist, which is not really an issue in New York City, of which we have many, including those here at Mount Sinai, but finding the right doctor to partner with. You're going to have this doctor, you hope, if you stay with them for a long time, and finding the doctor who you feel good about in terms of how aggressive they are or are not with the disease, how they talk with you, how they help you deal with different symptoms, what is the team that's around them to help. So you really are looking for a partner, and that can be very difficult in the beginning. Making the difficult treatment decision. Should I start treatment? And which medication of these 22 are right for me? Sometimes these are hard decisions related not just to you and your risk benefit kind of balance and your doctor. Sometimes it also includes insurance. What will your insurance cover? Because not all insurances cover all of the medications. and making disclosure decisions, why, whom, what, and when to tell. So we can be talking about family, we can be talking about your children, your parents, if you're dating, how to deal with that. And of course, we're also talking about your employer, when, how, when's the right time, which is talking not only about, we're also talking about legal issues and protecting your employment sometimes, and really knowing how and when to do that. And again, dealing with reactions of others, communicating one needs to others, particularly if you have an invisible symptom, building a support network, and beginning to plan for uncertainty, including maintaining employment, looking for the future, financial planning for the future, something we all should be doing, but particularly if you have MS, is a good thing to do. And even advanced directives. Again, not necessarily because you have MS, because we should all be dealing with advanced directives. But these are things that you really need to begin to think about. And particularly if you're in your 20s or 30s, those aren't easy things. Quickly, major challenges for those people with transitioning multiple sclerosis. So those who perhaps are finding that there is greater disease progression, greater disability that is not going away. Maybe those who are moving into this secondary progressive time from relapsing remitting, when there's perhaps fewer attacks or exacerbations, but again, just slow disease progression. You may be finding yourself less able to perform major roles. Perhaps you really can't be driving anymore. Perhaps you're having difficulty with work because of either cognitive issues or fatigue or any one of the symptoms. There's a need for more planning, problem solving with your family and with yourself, and impacted by perhaps more depression and cognitive symptoms, which I'll talk a little bit more about in a few moments. This is a time when there's really a need to continue treatments, and sometimes that's really difficult for people who've been taking these expensive medications and perhaps they're not seeing the results because their disease is progressing anyway. This can be a time for people to say, give up, or this isn't working. But it's also a time that the treatment that they really need to be dealing with is not just medication, but it might also be rehab, physical therapy, occupational therapy, it might be counseling. It's a time for really, again, learning to control things that one can control, even if you can't control the disease itself in MS. There's been a lot of research that has been going on, particularly of late, that are really looking at exercise, diet, spirituality, productivity, all of which can really affect general wellness. But we're also looking how it can reduce secondary effects of disability. And a lot of the research is looking at the possibility that some of these sort of lifestyle issues might have the possibility of slowing the course of the disease, and perhaps even rebuilding some axonal pathways that have been damaged by MS. Although some of that is preliminary, but what we are looking at is real associations besides at physical exercise and diet on a general wellness. So what we're also seeing is that if we can increase, we've been looking a lot at resilience, and I know that's been big in a lot of diseases and illness, but one of the things we've been looking at is who copes well and who does not cope well with lots of things in life, but that includes disease and chronic diseases and progressive diseases like multiple sclerosis. And they've been looking at some of the issues of resilience. Who is more resilient than others? And one of the things that there's been a lot of studies about are the skills of resilience. Can they be taught? And some people may be taught how to be more resilient, how to learn to cope, how we can have more control over some of these issues that are maybe taught by their family, but those who perhaps haven't learned them from childhood could still be taught now and with these diseases. And will they do better in coping with some of the major challenges of life and MS? As someone has more progressive MS, of course, there's greater challenges. So what we see is that the grief work continues always, always. More progression equals, of course, more loss. Who am I now? You have to, as they redefine themselves, that I can no longer do many of the things I used to do. What are my strengths? What do I have to offer? Who am I to others? What does control mean to me? Do I assume control of my life and my body by accessing available resources, using adaptive equipment, managing the aides who now come to help me, even though I may feel more and more dependent on all of these things? Are there elements of control that I can have by controlling these things that aid me? Am I willing to see things differently and to do things differently in order to do them independently? Can I allow myself really to see, and this becomes a big issue for those, say, who are needing to move to using a cane or using a wheelchair, or having an aide come to their house to help them with dressing, someone with helping them dress in the morning and get ready in the morning. Can I see these as aids and help that will help me be more independent? And these are big issues for people, because as we begin to feel more dependent on these things, but it is really the way to greater independence. And that can be a big piece of counseling in order to be able to see these things. And for some people, it's trying to find something that we might call the MS free zone. What are the MS seems to have taken over my entire life, but what are the parts of me that perhaps are free from MS, that MS have not changed? Whether it be my sense of humor, my ability to do parts of my job, my relationship with my children. It could be anything, and helping someone find those areas can really be key for them dealing with the challenges of becoming more impaired physically. So again, identifying new goals, directions, areas of focus, coping with caregiving challenges, which could be its own, certainly its own workshop or presentation. Caregivers are spouses, they're partners, sometimes they're parents, sometimes they're adult children, sometimes they're young children. Parents and caregivers often need help communicating their needs also. Too often, they'll engage in a silent battle in terms of who has it worse. Is it the person with the debilitating disease, or the person whose life is drastically altered by a disease that isn't even their own, but somehow it's taken over their own life? And being able to keep that communication going, even when there's so many feelings of loss and grief that's happening for everyone, can be definitely a challenge, particularly with more progressive MS. And of course, dealing with long-term care options. So as someone may become more impaired, there's a continuum of options, from assistance in the home to daycare programs, nursing homes. And families often end up making important decisions about these things at times of crisis, when something can't happen anymore, or they can't deal with something anymore, when they're least able to really consider the options carefully. So the more we as social workers and as counselors, as nurses, as others can really help families communicate about these needs and issues and look at the options before it's a crisis, the more that we can help them in making the best decisions for the entire family. What do we know about depression? So let's about in MS. And one of the reasons that we really think it's important to talk about depression is that we all know that it differs from normal grieving, and it can be challenging to diagnose in MS because of overlapping symptoms. It can look like fatigue, and depression can look like, and it also can look like cognitive changes. But we do know, when we really do an assessment, is that people with MS are at a high risk for depression. It's actually one of the most common symptoms of MS. And it's actually much more common in MS than it is in other progressive and chronic illnesses. So though we know that it is not just a reaction to having a chronic illness. So what we know over time is that it is also part of one of the symptoms of MS itself, and resulting from changes in the immune system and in the brain. So again, it's not just a reaction to having MS, but it's part of the progression of MS also. So more than 50% of people with MS will experience a major depressive episode at some point over the course of the disease. What we also know about for people with MS is that it's often underdiagnosed. And again, sometimes because it is mistaken for other symptoms, it is underdiagnosed, sometimes because it is hidden, that patients are afraid to talk about it. They're afraid, they want to be good patients and they don't want to tell the neurologist or their healthcare people, providers, that they are not feeling well, and or they really try to keep it from their family because it feels like they're not doing their part. So with the disease, they're not like bucking up. So there's a lot of stigma to this. So we really try to help both healthcare providers and patients know how common depression is, that it is really a symptom just like any other symptom of MS, and really work to try to get it treated. Having a depression screening as part of an assessment in a regular way is something that the MS Society and others really push, with MS centers and with other practitioners, and a referral, because it is also one of the most treatable symptoms, with medication, with counseling, and other wellness activities. Important to point at particularly at risk points, at diagnosis, at relapses, at major transitions, and at any time for people living with MS, that it's actually 2 times more common in MS, suicide itself, than in the general population. And so, of course, the greatest risk factor for suicide in MS is depression. So prompt recognition and treatment of it is critical. In one study, just to say that depression, together with alcohol abuse and social isolation, accounted for an 85% predictive accuracy for suicidal intent. So it's there. It's really a risk factor for many people with MS. And the most important piece for all of us to know is that it really needs to be asked about, just like any other symptom. Cognitive changes is also an important piece of learning about in MS. at least 65% of people experience cognitive changes in multiple sclerosis. It actually correlates with the number of lesions and lesion areas on MRI, as well as brain atrophy, which means that what we know is as the myelin is damaged and the axons are damaged, eventually there will be what we call like black holes because the axons have disappeared. And then the brain actually shrinks on itself. And a lot of that is affects cognitive functioning. However, it can, even though it is more related and correlates with more progressive disease, it actually can occur at any time, even as a first symptom, even if it is more common later in the disease. And it does not correlate with physical disability. So someone who is incredibly physically disabled may not have any cognitive symptoms, and someone who has no physical disability may be very cognitively impaired. So one of the first things is to not make any assumptions when someone just walks into your office or comes into your office. And yes.
Andrea, just so you know, we did have a question in the
Sure.
chat, which Debbie had going back and forth with, but what other diseases may people be misdiagnosed with that walk in with MS symptoms?
Okay. What we can say is often common, and I don't know if you said this, Debbie, I'm not looking at the chat. Lyme disease is one of the things that's often common because we're looking at fatigue and some of those same autoimmune sort of issues that come along. A lot of different neurological diseases that may not be as common, but are possible. It's really why it is important to have MRIs and to really also know that you need to have the lesions. They need to look at the lesions, where they are placed, the time, and also over time, and the symptom picture. It's less common for people to be misdiagnosed over a long period than it used to be now that we have MRIs and we do have a specific criteria. But it certainly can happen if people are not having a common course. Maybe you're not having lesions in common areas, and it can take some time to have the appropriate diagnosis. But there are other lookalike diseases, which is why you don't want to necessarily go on disease-modifying medications until the diagnosis is clear. However, and this is often the conundrum, part of the reason that we're looking at clinically isolated syndrome when someone doesn't meet the full criteria and may or may not develop into MS is that we now know how effective early treatment is. So there's always a question for the doctor and for the person looking at the diagnosis to try to figure out when to start treatment.
I don't remember what it's called. It might be something like optic neuromyelitis or something like that that really affects the vision, and that's very closely related to MS.
Right. There are other demyelinating diseases that are progressive that are not MS. Again, so this is why you really do need to go to a specialist to really take a look at the MRI, look at the history, and sometimes have a second opinion and third opinion if it's not really clear.
And Andrea, someone is asking, what do you recommend someone with MS getting COVID? What should they do?
If they have MS and if they have COVID, they should first do what anyone would do with having COVID. They should get treated for the COVID. They should, of course, also be talking with their neurologist to figure out what other steps they might want to take. and talk to all of your doctors. But the best advice that we're seeing right now is to treat the COVID, but to be aware so that whoever is treating you for your COVID, whether it's in the hospital or your primary care physician, is in contact with your neurologist and figuring out with you what the best course is. Whether to go off a treatment or do something with treatment is definitely something that you need to talk with your neurologist about. Right now, the general recommendations are not to go off of your MS treatment, but to do all the safety features, to isolate yourself and to be very careful, to try to not become positive for COVID in the first place. But there's no one answer for every person, so which is why the real issue is to be in close communication with your neurologist. The other piece that we can really talk about is really also, I mean, there's lots and lots and lots of information on the National MS Society webpage. And actually, I can go quickly forward here just to get you there. Just because I'm also aware of what time it is, that for people living with MS and for clinicians, there is lots of information on our website, both about dealing with MS in general, but also particularly dealing with COVID information. And I can tell you that the COVID information, particularly for clinicians, but also for people living with MS, changes. Sometimes it feels like daily, but almost weekly. We keep it incredibly up to date, and it really has some good information there.
Andrea, would you be able to share your slide deck with me so that I can send it to those who registered? So
definitely,
links.
definitely.
Great.
Right, definitely, we can send that to you.
I see that we've reached our time, and so I want to be respectful of people's time. If you need to jump off, we understand that. If you have time and you want to stay on, we'll continue to talk.
Yeah. Why don't we try to wrap it up in like 5 minutes? Yeah.
Okay.
Okay.
So I think a good place is that, let me just say this and then we'll go to Debbie, is that there's a lot that we know about MS today. And the picture is very different than 30 years ago. Debbie and I were just even talking, because Debbie's been here, 22 years at the society or something like that, and I'm like 18, that what we say now in these presentations is very, very different than what we used to say when we first worked here. And that there's lots of information here. And Debbie, why don't you take the last couple of minutes just to talk a little bit more about the society.
Okay, I can maybe
in 2 minutes.
Maybe blow through this quickly. I've been with the society for 26 years, which don't do that math.
She was 12 when she started.
Yeah. So the MS Society, the vision is a world free of MS, and to that end, we're guided by a plan to mobilize all human and financial resources to find solutions for people every day. I'm going to make you go quickly through these.
So here's important.
So yes, this is a very important slide. This is our MS navigators are made up of highly skilled professionals who work one-on-one with people and families, finding solutions for very complex challenges of MS. They provide information and referrals to service providers. They provide case management. They can provide financial assistance, and they're available from 9 a.m. to 7 p.m. Monday through Friday. Next slide. So our other services that we provide are like programs. So some in-person programs, online virtual programs, phone-based programs, some of them education on symptom management or research that's current. We have monthly webinars and weekly Ask the Expert programs. We recently completed our very first virtual Black MS experience, which took place over 3 days and was a variety of topics. We had nearly 600 people participate. which was great. All of our activities are on a website calendar. So just so you know, when you go to the National MS Society, you can click on the calendar and see everything that's going on. Our advocacy department works really hard on meeting with legislators on topics that are important to people with disabilities. We lobby our legislators at the state level and on the federal level annually. We have district activist leaders who work within a community on a targeted legislator. So for instance, if we're trying to get appropriate money from the National Institutes of Health, we might target the chair of the Appropriations Committee and send a volunteer in there. We are the largest private funder of MS research in the world. You can see how committed we are to that. Our founder, Sylvia Lowry, started the MS Society by looking for someone who had been cured of multiple sclerosis, and when she found that nobody had, she saw, you know, a need in the community, and we have now become a global movement. Some of the breakthroughs that we've made include we've had something to do with the 22 FDA treatments that we talked about. Exercise at one point, when I first started working here, was thought to be a bad thing for people with MS, and we now know that that's not true. And then again, the prevalence study that that we had talked about earlier. Our goal is to stop MS, restore lost function, and end MS forever. And the way you can get involved is you can become an advocate. You can do what we did here today by raise awareness, invite us to come again. You can volunteer your time as an event participant if you like to bike. This Saturday is our Bike MS event, and Andrea and I are riding. You can go to Walk MS. You can, if you don't really want to participate as an event, you can come and volunteer, cheering the rest of us on. You know whatever you want to do, we want you to be part of the MS movement. And by having us here today, you have started that. So thank you very much.